This is a little Jeopardy game I made for NUR 200 for their nutrition class that I had thought I would play in class, but as it turns out, it's not going to be there. So I'm going to go ahead and put this on Camtasia so you can flip through it and look at that. If any of this is particularly foreign to you, you may want to go back and review some of this content. There are 2 Camtasias that are nutrition Camtasias also posted on the NUR 200 site in Canvas. So that is good information. They're a little bit long. They're about an hour a piece, I think, and they're a little bit long, but go ahead and listen to them because it is very good information, and this is stuff that you'll need to know for your nursing career and for your life. It's just interesting stuff. But this is just a little review of some things I wanted to hit the highlights on. Under the nutrients category, the first question is, this food group yields 4 kilocalories per gram and should be 50 to 60% of the total daily calorie intake. Answer to that is carbohydrates. Protein is 4 kilocalories per gram. That should be about 10% of your daily calorie intake. And fats have more calories per gram. They're 9 kilocalories per gram. It should be about 20 to 35% of your daily intake. We have gone from the food pyramid of many years ago to more recent years of something called My Plate, that is just a drawing of a plate that has portions on it of proteins, fruits and vegetables, and milk on it, to help people understand what is reasonable in their diet. And of course, these diet requirements change based on what somebody's medical issues are. But it is important that you understand the concepts of diet and the different types of foods and what the types of foods are, so you can help teach your patient about these things. Question. This represents the body's carbohydrate store and helps to support the blood glucose during sleep. So this is particularly important when you're talking about your diabetic patients and helping to manage blood sugars. Answer to that is glycogen. Glycogen is where excess carbohydrates are stored in the liver, and in times of low blood sugar, glucagon from the pancreas, from the alpha cells in the pancreas, stimulates the breakdown of that glycogen into glucose to go back into the cell. This is why sometimes if our patients are hypoglycemic and they do not have, can't take PO, or we can't give them a D50 through an IV, sometimes you'll actually give IM glucagon to these people. And that's because this glucagon, because their pancreas is dysfunctional, they're diabetic, and they don't have this glucagon from their pancreas. So the exogenous glucagon that we give them IM actually stimulates the glycogen in the liver to stimulate glucose in their blood. So, what is the desirable blood total cholesterol level for patients trying to limit fat to minimize heart disease? Total cholesterol needs to be below 200 milligrams per deciliter. You know, the LDLs, which are the lousy lipids, those are the ones we don't like. They like for them to run below 100. The HDLs, we call those the happy lipids, they need to be more than 40 on their lipid profile. So those are some numbers that you're aiming for with your patient that has a potential for hyperlipidemia, and you're checking their blood lipid profiles. Oops, sorry, did that one already. Black beans and rice, macaroni and cheese are examples of what kinds of proteins? Answer, those are complementary proteins. Remember, there are proteins out there that are not just meat. So in a patient that is, for instance, a vegetarian, or a patient that is, for whatever reason, doesn't consume as much meat as to meet all of their protein needs, you can combine incomplete proteins to make a complete protein. And you need to be aware of those things so you can teach patients about it. Somebody might not think of macaroni and cheese as having protein in it, but it does. Your renal patient returns from dialysis and his weight is 11 pounds lighter than his weight before the procedure. We know that before they go to dialysis, a patient gets weighed in the hospital, and then they will weigh them when they come off of dialysis. So how much fluid, how much water did the dialysis machine take off if your patient is 11 pounds lighter on his weight? This is an important thing to look at in your patient's hydration status and your patient's INO. You need to know how to calculate this when you're taking care of renal patients. So the answer is this person has lost 5 liters. We know that because 11 pounds divided by 2.2 is 5 kilograms. We know that a kilogram weighs a liter of fluid. So a patient that is down 5 kilograms on his weight is down 5 liters of fluid. That's important when you're giving someone diuretics, that you are doing daily weights on for heart failure. It's important that you look at their INO, follow that INO, and make sure that you can correlate what you're seeing on the INO sheet to what their weight is doing, so you can make sure it's accurate. Under micronutrients, these are the vitamins and minerals. What are the fat-soluble vitamins? There's 4 of them. A, D, E, and K. It's important to remember these because these are the ones that your body stores. These are the ones that you can potentially overdose on. People can get toxic from these because they're stored in the body. Sunlight is the primary source of this particular vitamin. Vitamin D. Vitamin D deficiencies there's a lot of information out there about that lately, and you hear a lot about people getting their vitamin D levels checked and getting supplementation to their vitamin D levels. But one important way these people can get vitamin D is through sunlight. Remember, people that use a lot of sunscreen, and we're very conscientious about sunscreen now, or keeping ourselves covered up or staying out of the sun. We're very conscientious about that because of the risk of skin cancer and of course wrinkles. And it is very important to be aware of that, but then also be aware that this person may be vitamin D deficient as a result of all that staying away from sunlight. This vitamin is essential in a clotting cascade and is given to newborns. This is something, if you've worked with babies or you remember working in the newborn nursery, you gave this. This is that little, how they say you do eyes and thighs on new babies. Well, the eyes is the antibiotic you put in the eyes, and the vitamin K is the shot that you give. Vitamin K is synthesized by the bacteria in your gut. That's where you get your vitamin K from. Newborns do not have that vitamin K because they don't have bacteria in their gut yet. They have a sterile gut. You need vitamin K to help facilitate the calcium function in the clotting cascade. So it's important that newborns get this vitamin K for their clotting factors. Also, it's important that we monitor intake of vitamin K on our patients that are anticoagulated, because it can make a difference in their anticoagulation how much vitamin K they're taking in. It's not that they can't take it in, it's that they need to keep a stable, normal amount coming in. If they eat greens twice a week, turnip greens or collard greens twice a week, and then they decide they're going to eat them every meal for 2 days, it can make a difference because of the vitamin K content in that. It can make a difference in their clotting times. So we need to be aware that we teach our patients about that. Which vitamin requires intrinsic factor to be absorbed in the gut and is often deficient in patients experience alcoholic gastritis? We see this a lot in our hospitalized patients that come in for detox, or people that have liver problems associated with alcohol. B12 is given to prevent pernicious anemia in these people. People that have alcoholic gastritis have a decreased secretion of intrinsic factor in the from the gastric cells, and so they are deficient of this. You need that intrinsic factor to absorb B12, and B vitamins are important in a lot of different ways, but one way is it helps to prevent a pernicious anemia. They can develop pernicious anemias with a lack of B12, which you do see in alcoholics. So you may be given that supplementation. You may even be given an IM in the hospital. And a lot of times when I see somebody getting that, that's what I think is this person have a history of alcohol or that kind of thing. gastritis of some sort. Which mineral is important in muscle contraction and bone formation and causes tetany of the muscles if it's deficient? These are people that have muscle spasms. Oops, sorry, did the wrong thing. Calcium. People that have hypocalcemia, these are our pancreatic patients. There's a lot of different reasons people can have hypocalcemia, and you'll learn about some of them as you get into 201. These people and your parathyroid patients too also can have problems with it, but these people can have a facial twitching if you tap them on the cheek, on the facial nerve. They'll get a little twitch kind of in their upper lip and on the side of their cheek. That is called Chopstick's sign. And when you blow a blood pressure cuff up on these people, you'll see their hands spasm. It's called Trousseau's sign. When you're inflating the blood pressure cuff and you see their hand curl up in spasm, it's kind of a hand and wrist spasm, lower arm. That is Trousseau's sign. So that puts these people at risk for muscle spasms. Also osteoporosis if they chronically have low calciums. What are the water-soluble vitamins? The B vitamins are water-soluble. You see those listed there. B1, which is thiamine. B2, which is riboflavin, niacin. B6, which is pyroxene. Folic acid. B12, which is cyanocobalamin. I never can pronounce that. The B vitamins are water-soluble vitamins, as well as vitamin C. So we see our patients taking, especially vitamin C, mega doses of vitamin C, thinking that it helps. Actually, they're just urinating out all this vitamin C because it is water-soluble and it's not stored in the body. So you can save them some money and say, if you take the right amount every day, you're going to do better than to try to take mega doses of these water-soluble vitamins. This vitamin is an important antioxidant, reducing the free radicals released during oxidation that can cause cell damage and death. Vitamin E. You hear a lot about vitamin E these days with regard to dementia and Alzheimer's, prevention of mental deterioration in elderly. You hear a lot about vitamin E with regard to skin care and beauty and those kind of things, aging. Antioxidants used to be a new concept. Now it's been around, I don't know, probably 10, 15, 20 years you've heard about antioxidants. There are ions in your body called free radicals that are released by different processes in your body, and these are ions that are not paired. We traditionally like an oxygen that is not O2. It's just a free oxygen radical that's not bound with another free oxygen radical. It's not O2, which is oxygen that we think about breathing. And there's several of those that can float around the body from the breakdown of different processes. And those free radicals are free to bind with other substances and potentially cause damage, is what free radicals are supposed to do to you. So vitamin E is supposed to help, and antioxidants are supposed, and it's not just vitamin E, there's several antioxidants that are supposed to help reduce the damage from these free radicals. So if you hear about antioxidants, it's I think B vitamins also are that way. That's what it's talking about. Oops, I've done that one, sorry. This is an important mineral found. This mineral is important in the formation of hemoglobin and can be found in meat, among other sources. This is iron. Our patients that have low hemoglobin may be because they have a deficiency of iron. The heme part of hemoglobin is iron. So if we have to look at our iron deficient patients to see if they have anemias. So you'll see a supplementation given in the hospital very often for anemic patients. And of course with iron we have to be careful. It has some gastric side effects, plus it can make the stools very black, and that's something that we have to think about. Therapeutic diets. What should a patient increase in his diet to counteract complaints of constipation? So you have a patient that's complaining of constipation, and what do you think you need to tell him? Increase his fiber and increase his water. We know that increasing the fiber helps bulk up the stool, and so there's more volume to it to move on through. But you have to have the water in there too, or else you can, with fiber, cause more constipation. So you have to be sure when you tell them to take their fiber supplements or take their increase in their fruits and vegetables, they also take in more water with that to keep themselves regular. A meal on this diet might consist of gelatin, popsicles, bouillon, and Sprite. Those of y'all that have worked in the hospital have seen this meal before. It's just not very appetizing, but our patients get it when they're on a clear liquid diet. Most often, these are maybe post-op people that were trying to start back on a little bit of food just to see if they can tolerate it, or maybe somebody that's got nausea and vomiting, or they've got diarrhea, and we don't want to give them anything that's going to aggravate the situation, so we may give them sips of clear liquids. Be aware of anything that you cannot see through at room temperature is not a clear liquid, but if you can see through it at room temperature, like a popsicle, that is, of course it wouldn't be a popsicle at room temperature, but that is a clear liquid. The full liquids is more the milks and the cream soups and that kind of thing. Which diet is ordered for a patient to lower body fluid and promote excretion of water? Sodium restricted. We know that water follows sodium. People take in too much sodium, they will retain too much fluid. You know this if you've been out to eat Mexican at night and you eat too many nachos or whatever, and you get up the next morning and your rings won't fit and your eyes are swollen. You're like, well, what's up with that? Well, you have a lot of sodium in your body. You'll learn when you get into endocrine in 201 that your aldosterone system is very efficient in keeping our sodium levels exactly where they need to be. So you take in too much sodium, your body's going to say, hey, we need to retain some water. So this is okay for you if you're having normal physical situation, if you don't have any medical problems. Eventually your things will regulate. You just drink some more fluid and you'll start getting rid of the sodium. But in patients with heart failure or hypertension or cirrhosis, things that they may retain fluid anyway, or they may have too much fluid on board anyway, you need to make sure that these people do not get too much sodium, because it can make your blood pressure go up. It can make you retain fluid in your lungs or in your abdomen if you have a problem with that anyway. So, why would a patient have a low residue diet order? You may see this order in your surgery patients, and you're like, well, what about the low residue diet order or the GI patients? Low residue diet means you want to minimize the bowel activity. You want to keep the volume and the frequency of the stools low, so you give them things that don't have a lot of bulk to it. Little bit different than just low fiber, but this is something like that's had lower bowel surgery, and they don't want them to, maybe they've had hemorrhoid surgery and you don't want them to stool a lot the first few days, and so they may put them on a low residue diet. Somebody that's got an inflammatory process of the bowel, you have absorption problems when your bowel is inflamed, like diverticulitis or colitis, the different colitis, and you'll learn about that in 201. These are people that they have problem with stuff just racing on through anyway. It doesn't get absorbed. The fluids don't get reabsorbed because they have inflammatory processes going on. So they don't need to have more bowel activity going on than absolutely necessary. So they may have a low residue diet. Or somebody that's on a bowel prep for surgery, like you're going to have a colonoscopy, or going to have something. They may put them on just a clear liquids or full liquids or whatever that doesn't have a lot of residue in it. But it prolongs the transit time of the bowel. People that you don't want them to have a lot of stuff racing through their bowel, that a low residue diet prolongs that. So, let's see if there's one more. There are. Okay. List 3 advantages of feeding a dysphagic patient with a functional GI tract enterally, which means through a tube feeding or through the gut, rather than parenterally, which is, for instance, IV TPN. When you hear enteral feedings, that means it's something that's going through the gut. When you hear parenteral, that means around the gut, basically IV. So what are the advantages of giving this dysphasic patient enteral feedings instead of parenteral feedings? Answer being, enteral feedings maintain the normal bowel function as much as possible. They help maintain those cells along the GI tract that they have a function. They have a function of excretion and digestion and all those things. And if you can maintain that, it's better for the patient in the long run. To be able to keep something going through the bowel in the long run, it's better. Decreased incidence of infection. We know that TPN has an increased incidence of infection in the IV, so you're decreasing the incidence of that. We know that people that get TPN sometimes have more imbalances of their blood sugars and electrolytes and all of that. So it's better to give those an enteral feeding. It helps to keep all that stuff more balanced, as well as proteins. It's difficult to give a lot of proteins in the TPN. I get amino acids, but that's just not the same as being able to give enteral protein into the GI tract and have it perform its function. Last but not least, here are some questions about tube feedings. If you were the RN, what would you do? What would the RN do if the patient pulls his NG tube feeding out? And you've had this happen, I'm sure, if you've worked in the hospital. Darn those patients. So what you do? Well, you replace it, which sounds silly, but you realize the nurse can replace an NG tube, and most of the time a nasoduodenal tube, which is one of the duo feeds or the keo feed tubes, without notifying the MD, assuming you have an initial order to do it. But be aware that hospitals have policies. Typically, there's an x-ray confirmation that's required before you can restart the feeding. So you don't just job it in there, listen for air, and then hook it back up. If that NG is not in the right place, the patient aspirates, and you haven't followed hospital policy, you're going to be in a mess. So what you need to do is make sure you know hospital policy, get an x-ray confirmation before restarting the feedings if that's the policy. Evidence-based practice says that auscultation of air on installation is not reliable. Some hospitals say check the pH of the aspirate, which obviously is cheaper than doing a chest x-ray. The gastric pH typically is 1 to 4. It's more acidic. If it's a duo feed or a duodenal tube, the duodenal pH is going to be higher than that. It's going to be more alkaline. But you need to know your hospital policy. Once you've replaced that NG tube or that in that nasoduodenal tube, you need to know your hospital policy for check and placement before you put that tube feeding back up. It covers you. What do you do if the tube feeding becomes clogged? Irrigate it with water. If you've given tube feedings along the way in the nursing home or wherever, you have had a feeding tube that got clogged up. You've probably tried to use cola. You've tried to use cranberry sauce. You've used all this kind of stuff on cranberry sauce, cranberry juice, to try and supposedly the acid eats it up or whatever. Evidence shows in the literature there is no advantage to using Coke or Sprite or cranberry juice, that water will irrigate it just as well as anything. There are enzymatic solutions that you can use, or pancreatic enzymes that you can use to put into the tube and eat it up. I think BioCase is the one we used to use at East Alabama. The thing is, you need a doctor's order to do that. So the pharmacy usually won't even give it to you without a doctor's order. So whatever, there may be a protocol order, there may be routine orders, you may have to call the doctor and get an order, but there are enzymatic solutions you can put in there to try and open up that tube. Now, obviously, if it's really, really occluded and it doesn't work, you're going to have to replace the tube. So prevention is the best solution. So flush that tube before you give medicines. Flush that tube after you give medicines. If they're on a continuous tube feeding, make sure that that flush every hour or every 2 hours or whatever is done. A lot of pumps will automatically do that for you. Just make sure that tube is getting maintained and flushed like it should. What would you do if your patient appears to have aspirated his tube feeding? And this is scary and this is bad. We know people can die from this. Turn your patient on the side, because if there's stuff in that oral pharynx, you want it to come out. You don't want it to be stuck in there. Turn him on his side, suction him out. You may have to get a nasotracheal suction or an oral tracheal suction kit out and suction him out, or you may be able to get it with a yanker. Just get in there and get out what needs to get out. Notify the MD, we think Mr. So-and-so is aspirated. Anticipate that MD may order a chest x-ray to see what's going on. It may require intubation of that patient if they're severely compromised, and I've seen that happen too. I've seen people that aspirated on their tube feedings or whatever, and they actually had to be put on the ventilator because we needed to get down in there and suction out that stuff out of the lungs. Once again, prevention is the best solution for this. Prevent aspiration by elevate the head of the bed. Any time your patient is getting stuff through an NG tube or a PEG tube, you need to have the head of that bed elevated, especially if it's a nasogastric tube, because you're going through that sphincter. If your patient has to be flat in bed for some period of time, you need to turn off the tube feedings. You know, we tend to go in and turn off the tube feedings because we're going to turn them, we're going to bathe them, or so we turn off the tube feedings. Well, the tube feeding's only been off for 3 minutes. Do you really think that makes a difference in what's in his stomach or not? So be aware that if you have a patient that needs to be flat for some period of time, you're worried about aspiration, you need to turn that tube feeding off in a timely manner so that stuff will get out of his stomach before you flatten him out. Check the residuals. Every time you feed him, you need to know what the residuals are, or check it every 4 hours if it's a continuous feeding. If there's residual present, typically you hold it for an hour and recheck. Now, this varies from institution to institution and physician to physician how much. I have heard if it's 1 1/2 times what the patient is getting in an hour, that you should hold it. It just depends on what the protocol is for your institution. But just be aware, the whole idea is you don't want a lot of residual building up in there. That means it's not going on through, and that means the patient's at risk for aspirating as well as not getting their nutrition. What would the RN do if the patient receiving enteral feedings is having cramping and or frequent diarrhea? And you've had this happen to you too if you've dealt very much with patients that have NG tube feedings. You know they're going to have some diarrhea sometimes. If it's more than 3 times in 24 hours, typically you need to notify the MD and consult dietary. There are some changes that may need to be made. What may help? Decreasing the rate. Sometimes people are just getting too much too fast. Changing to a more isotonic feeding. Some are more hypertonic than others. The hypertonic fluids are going to pull water into the bowel. So if somebody's having diarrhea, you need something that's more isotonic, like isocal. We used to give isocal a lot. Administer feedings at room temperature. You may not think about it, but a lot of these places, these hospitals will refrigerate their enteral tube feedings until it's time to put them up. And that really needs to be at room temperature, or it can cause some diarrhea. Consider other causes for diarrhea. Is the patient on antibiotics? And we know antibiotics cause diarrhea because it kills off the normal flora in the gut. Some people are on medicines that contain sorbitol or lactulose. That will cause diarrhea. Some tube feeds can be contaminated with bacteria, and the patient can have a bacterial GI problem that's causing that. We may have to culture the stools. A lot of times they'll do a stool for CNS and a stool for O&P, or and see if there's C. diff or if there's some sort of ovum parasite in there. So just be aware of that. These patients may be at risk for dehydration. These patients need to make sure they're getting their flush every so often. Not only keep their tube feeding, but also keep their tube open, but also to give them some water. Some doctors will go ahead and dilute out the tube feeding to increase the water, or just increase how much you're putting in there once an hour or once every 4 hours. But be sure that these people are not getting dehydrated with all this diarrhea. Okay, and last but not least, what would the RN do if the patient receiving nasogastric enteral feedings needs a PO med? And we say this all the time. They've got an NG tube, they're getting feedings, and the MAR says, give such and such PO. You're like, well, okay, well, what am I going to do about that? Every now and then, somebody can swallow something PO if they're getting like peg tube feedings. Realize that getting somebody to swallow with an NG tube in is risky because they're not going to have a good swallowing reflex with that big tube down there. So what do we need to do? We need to make sure the medication is something that can be crushed if we're going to crush it. Remember, extended release quite often can't be crushed. Sometimes if it's an extended release capsule, you can call the pharmacy and they'll say, go ahead and open up the capsule. Those little tiny little round things inside the capsule are actually what is extended release. It's not the capsule itself. So sometimes capsules you can open up and give, even though they claim to be extended release. Some medicines are available in a liquid form. So check with the pharmacy. There may be something that you can substitute the liquid form for the PO form. This has got a typo on it, sorry, but notify the MD the route needs to be changed. You don't have to call him in the middle of the day. I wouldn't think at the office about this, but you may have to. I don't know. It depends on the physician. But be aware that the order does not need to say PO on there, and you're giving it by NG. That is not, you're not following the order, basically. And if you ever get called to court about it, you don't ever want to have to defend that. So if you need to change it, you see the doc and go, look, this is ordered PO. Can we just change this order to NG? Then there you go. You need to do that. Or vice versa. Sometimes people are getting NG meds and they get the NG tube out. Well, then you've got a bunch of NG meds ordered and the NG tube's not in there, so you need to get an order to change those to PO, so you'll be following the physician's order. Check for compatibility of the feeding and the medication. What comes to mind to me is Dilantin. We know with Dilantin, typically you'll stop the feeding an hour before and an hour after because it can't be given with all that, with the milky products in the tube feeding. So, and be sure and flush before and after all your drug doses to make sure you're not mixing the tube feeding with the medication. And that's all of that. Once again, if you've had if you're not familiar with the vitamins, you're not familiar with diets, those kind of things, be sure you go back and review that content. Some of this will be on your unit test, so just be aware of that. And it's important content for you to know in nursing and in life. So, thanks.